Good evening and Assalamu alaikum, everybody. I'm Dr. Shabeeha. I'm a consultant hematologist working here in Dubai. I thank Dr. Ahmed and the organizing committee for the invitation and asked me to speak on this occasion. I must congratulate the organizer for a fantastic meeting, very educational, and hopefully this talk will enlighten some of the presentations and main focus points for aggressive lymphoma, which is what I'll be talking about from past ASH in 2019. So my talk and the disclosures as we go. I have nothing to disclose and no disclaimers. I have chosen few questions which were addressed in the meeting, and we will talk through those questions, particularly about the diffuse large B-cell lymphoma in terms of the optimum treatment for low risk or early stage disease. The second question is about the benefit of adding ibrutinib to R-CHOP, and further on we talk about the CNS disease and the CNS relapse as we go along. So the first question to address from the meeting was about the FLIRE study, and we know that this was published earlier on in December, coming to January in Lancet, which was a non-inferiority trial by the German group, and this looked at the sort of non-inferiority of R-CHOP for 4 cycles followed by 2 rituximabs compared with the standard 6 cycles of R-CHOP chemotherapy in untreated aggressive B-cell lymphomas. The age group is classic between 18 to 60 years of age, with the stage of the disease, because it's early stage, so stage 1 and 2, and the age-adjusted IPI was taken as to be 0. The disease bulk was fairly minimum, as a maximum diameter of less than 7.5 centimeters, and roughly about nearly 588 patients were enrolled. The main primary endpoints were considered as to be the progression-free survival and 3-year PFS. The other endpoints were the response to therapy, the event-free survival, the overall survival, and the safety. And this is what the trial showed. Long behold, both the arms in terms of the standard R-CHOPs for 6 cycles compared with the R-CHOP given 4 times followed by 2 rituximab in almost an equivalence in the group of patients. There was nothing better, nothing worse. So it was a non-inferiority of both the treatment lines, and the median follow-up was for about 66 months, which is about 5.5, 6 years almost. And the PFS was noted to be non-inferior with R-CHOP followed by 2 rituximab compared with standard 6 R-CHOP chemotherapy regimens. Now, this was taken further in a more objective way, and there was another oral presentation done by the British Columbia group, which looked at the PET-guided or radiological assessment of the disease for the limited stage diffuse large B-cell lymphoma. And this trial was actually a cohort over 14 years and looked at the non-bulky disease, again, less than 10 centimeters, again, stage 1 or stage 2 disease, and over 300 patients were enrolled with a median age of 68. And the trial design of the schema is looking like this, that they had 3 cycles of R-CHOP followed by a PET scan, which conferred if the PET scan was negative, the patient were given 1 more cycle of R-CHOP. If they were PET scan positive with dual score of 4 or 5, they were given 30-gray radiotherapy. The factors predicting the positive PET scan was evaluated to be the elevated LDH, the tumor size of more than 5 centimeters, and a higher stage modified IPI. Within that group, as one can expect, the Kaplan-Meier shows that they had a better 5-year PFS with a PET negative group compared to the PET positive group, although the overall survival, as one would expect, the same.